So this is a joint, so I think it comes under the purview of musculoskeletal, though in highly subspecialized practices like ours, these are typically read by the head and neck radiologist. But a lot of the neuro people don't really like these. So let's just go through the anatomy of temporomandibular joint. We did a lot of imaging of this joint 15 to 20 years ago, and it's dropped off a lot over the last decade. And I think that's primarily because treatments that had been kind of designed with the anatomic abnormalities in mind turned out not to be very effective. So it's a much less common study now than it was in the past. So as far as the anatomy here, you're all familiar with the condyle here and the temporal bone, and this is called the mandibular fossa up through here. And then this is the anterior part of the disc, the intermediate zone, and the posterior aspect of the disc back here. This is the superior retrodiscal layer, which attaches the disc posteriorly here, and depending upon the position of the temporomandibular head, it can either be taut or kind of lax, like we're seeing here. 8 is the inferior discal attachment of the posterior part of the disc, and then there are a lot of vascular structures back here. And then as we go more anteriorly, here's the superior attachment anteriorly of the capsule, the inferior attachment, and this is called the superior recess. And down here, 13 is the inferior recess, and 14 here is the superior head of the lateral pterygoid muscle, which comes here and attaches in multiple places here. And then 15 is the inferior head of the lateral pterygoid muscle, and this is the interpterygoid space in between the two. And then here's the external auditory canal back here. So these are the structures that we're going to be looking at. And we'll typically look at these in the coronal as well as the sagittal planes predominantly. So here is the coronal plane where we can see this is the condyle and the mandibular fossa up here. This would be the discal layer in through here. And here's the sagittal plane. And typically...
Excuse me.
Yeah.
Was that a normal?
Yes, this is normal. Yes.
Okay, thank you.
Yep. And here's the sagittal plane, and we typically image in the open mouth and the closed mouth positions. This is the closed mouth position here. We can see that the condyle comes around here so that the teeth are clenched over here. The condyle is kind of up superiorly and posteriorly in the mandibular fossa, and right above it should be the posterior margin of the disc, and its attachments right here. The posterior edge of the disc should be somewhere around the 12 o'clock position. It can go from the 10 o'clock to kind of the 1 o'clock position here. This is that central area of the disc which becomes thin, and here's the anterior disc, and we can see some of the superior attachment anteriorly here of the disc. That's normal in the closed mouth position. In the open mouth position, what we see is that the condyle rotates. So now, instead of the neck of the condyle being angled forward, it's more vertical in this situation. The condyle itself now is translated anteriorly and inferiorly, and you can see how it's rotated. And now we can see it captures the disc, and the normal narrow part of the disc should be between the arcuate eminence, which is we see above, and the condylar head here, and this would be the posterior aspect of the disc, and the posterior aspect of the disc, and this is the anterior aspect of the disc. And notice how increased space you have here posteriorly, which is just filled by loose areolar tissue and the retrodiscal attachment structures when you're in the open mouth position.
One more question.
Yes.
Do you have an MRI of the opposite side?
We do not normally do both sides.
Sorry about that, because I don't think either side would be the same.
In completely normals, they should be very similar. In most individuals,
No, what I mean is that there would be some difference because when you open your mouth and close your mouth, your jaw moves from side to side, not just from up and down.
Okay. Yeah. Okay. Yeah. Typically, they'll be very similar if they're normal. But what we find in people who are abnormal, which is a lot of people, you'll have differences from side to side, and we'll see some of that later in the lecture. So this is just a schematic diagram of the closed mouth position, and then the open. This is the beginning of the open mouth. We're getting a little translation. You'll start getting more contact between the head and the discal tissues, and then as it rotates and moves forward, we can see that's in the open mouth position. And we often don't see these retrodiscal attachments very well, but you can see where they should be lax in the closed mouth position and taut in the open mouth position. And what we'll find, a lot of pathology we'll be seeing will be tears of these attachments, but we often can't see the actual tear in the attachment. We infer it by the abnormal displacement or abnormal displacement of the disc. And the other thing you can do is clench your teeth, which we don't normally do. That typically, this doesn't show up very well, will drive the head back up into the fossa here. This doesn't actually show it real well, where it'll move superiorly and compress the posterior band of the disc. And then here's just a T1 weighted, and these are slightly in the slightly oblique sagittal plane. You have to have coils right over the temporomandibular joint. Typically, these are 3-inch surface coils that are placed right over the temporomandibular joints. And then here, this is the closed mouth position. You can see the nice normal position of the posterior part of the disc. And this is the open mouth position where we can see rotation of the head. And now the disc, the head is moved into the central part of the disc, which separates the head from the arcuate eminence here.
Now, John.
Yes.
I'm gonna keep asking you questions, I guess. When the condyle on the left rotates one way, the condyle on the right rotates the opposite way, doesn't it?
Yes.
Okay, I just want that's we used to have. I'll give you a little history. I'm sure you know this, but the fellows may not. They used to make movies of these, and that was extremely common. And people used to do, well, surgeons used to do surgical procedures for this problem when there was a misalignment, etc.
Right.
And eventually that went into disrepute. We had a guy in my building that's all he did was jaw osteotomies for this problem. It was kind of interesting. He was very busy, but nowadays, well, we'll get to treatment later. Okay, sorry to interrupt, John.
No, that's fine. Now, as John said, we often did do movies at the beginning of evaluating this, where we would image the the temporomandibular joint in different degrees of opening of the mouth. We didn't do it both opening and closing, and then we'd play it back as a cine loop to try to get a sense of dynamic motion in it. This was popularized by a radiologist in Long Beach by the name of Keith Burnett, and he invented a device that is, you can ratchet, you can gradually increase the size of this opening. You put this between the teeth, and you ask the patient when you go in first, you have these two together, and then you have a closed mouth, and then you hit this ratchet once and it opens it a little bit. You do a quick scan, you ask them to hit it again, and all the way up to where they have maximum comfortable opening of the mouth, and that way you could get sometimes 5 to 10 images in different degrees of opening, and as John said, you could play it as a cine loop. And this was the Burnett device. We did that for maybe 5 to 6 years, And then we realized that really all the information we wanted could pretty much be contained just in the open and closed mouth views. So we stopped doing that maybe 20 years ago. Okay, here's a 42-year-old female with severe temporomandibular joint pain and also migraines. I mean, what do you think?
So, closed and open view. So, on the closed view, the disc looks abnormal signal there.
Well, this is actually pretty normal.
Okay.
There's normally a little bit of inhomogeneous signal intensity within the disc.
Okay.
And what about the open mouth view?
Open mouth view also.
Okay,
It's thin. I don't know. The disc is.
See, there's a little bit more increased signal intensity within it, but the margins are fairly sharply defined. And what happens often is when you get pressure on the disc, the margins are less well visualized, and so this is pretty common, which we see there. And then we always do a T2 weighted image, usually in the closed mouth position here to look for fluid in the joint space, and there's not a lot of fluid here. And then we do the coronal images. So what do you think about this one?
I think it's okay then.
Yeah, so this is a normal study, despite the. And one of the things that I'm going to point out as we go along here, patient symptoms don't correlate very well at all with the MRI findings, and that was another problem that we had. Sometimes people, when they have minor findings, will have a lot of pain, and over the years, the MR findings will get worse, but the pain gets better. And so that was also a problem that we had dealing with.
Dr. Cruz?
Yes.
Sorry, on the open mouth view, wasn't there fat filling in posterior to the temporal condyle?
No, it's
you showed us a normal original. Yeah, go ahead.
Loose areolar tissue, and
it's not fat.
It's not. No, it's generally not fat. Can have fat in it, but it's more kind of loose areolar tissue.
Thank you.
It's a space filler.
Yeah. Okay. So let's see.
There are no empty spaces in this joint area, or any joint actually.
Okay, unable to open mouth. So on the closed view, it looks like the disc is probably around 11 o'clock.
Okay, so there's kind of the edge of the disc. Obviously, these are early scans, and so the resolution isn't as great as we'd like. There's kind of the disc itself there. And this is in the open mouth position.
And it looks like the disc is, or the condyle is about where the mid disc is.
Yeah.
Which looks okay.
So one thing you always have to evaluate whenever you do these is there adequate opening of the mouth? And you should get anterior translation of the condylar head over the arcuate eminence here. And there's not adequate translation here.
I see.
So that's either due to poor effort on part of the patient or something else. In this patient, the patient couldn't open their mouth. So I guess the question here is then what's going on here? Here's what the T2 weighted image looked like.
Looks like a lot of fluid in the joint.
So we do see a fair amount of fluid here. And so what would your differential be?
For fluid in the joint, just sort of repetitive.
Well, for why they can't open the mouth.
For why they can't open, maybe like adhesions or scar tissue.
That's good. Now, that's what this is. This is adhesions. Now, what we'll see, a more common cause is actually anterior displacement of the disc, which is the primary reason that we were doing these in the old days. But also adhesions. Adhesions, you can go ahead and break up the adhesions. We'll talk about anterior displacement, but in this particular case, the disc is not abnormally displaced. We'll see those in a minute. This was a person who just had adhesions that from old trauma, which would not allow adequate motion on the condylar head. So this patient actually had surgery to lyse the adhesions.
Was this guy a boxer?
I do not remember, John. This was a long time ago.
Okay.
Yeah.
So where are the actual adhesions?
You often cannot see them, but they're typically all around the head.
Okay.
Okay. Let me see who we have. Vanessa. So, Sam, what do you think of this one? Vanessa.
Okay, well, they're bilateral, painful right click. So they're both closed, and they look pretty similar to me.
So, what do you see on these?
Well, they're closed, and the condylar head appears to be articulating, I guess, what I would expect to be.
Okay, so the condylar head is up in the fossa here, the mandibular fossa, but notice it's much higher than what we saw on the others.
Yeah.
It's actually
clenched,
maybe contacting the bone. And here, this is more posterior than we saw the others, and also maybe a little high with maybe a little bit of fluid up here. What else do you see? Okay.
No, I guess the teeth are clenched here. Is that what this is supposed to imply?
No, this isn't.
Loss of cartilage?
This is just the closed mouth position. What's this?
Pterygoid muscle, or I don't know which muscle that would be.
It's the same.
Well, that's the disc there. That's the disc there. Yeah, that's the disc. Oh, it's not articulating with the disc at all.
Okay, so in this case, on both sides, the disc is anteriorly displaced. See the anterior part of the disc, the central zone, the posterior part. And here also, this one's a little bit more, the morphology is a little bit more abnormal on the one on the right. It's anteriorly displaced. There's some kind of mass effect here. But notice that we don't see the normal soft tissues up here. So what do you think's happened here on these temporomandibular joints?
I guess chronic, subluxation maybe, or
yeah. So you have tears of the posterior attachments, right? There's no space up here. The bones, it's bone-on-bone articulation. So those posterior attachments are actually torn bilaterally, and we have anterior displacement of the temporomandibular joint disc. And this is the primary reason, primary diagnosis we were looking for when we did MR scan of the temporomandibular joints, and people still do these studies. Now,
John?
Yes.
I remember years ago, we used to think of this as a meniscus.
Right.
In many ways. So you think of the meniscus and what can happen to it. Similar things can happen to this joint.
That's right. So we have a basically displaced temporomandibular joint meniscus. And as you know, in the knee, if you have displaced menisci, you can end up with degenerative disease. So we'll talk about that. Now, this patient has a painful right click. The patient was pretty asymptomatic on the left side. So what do you think could cause the click, Sam? That's the other thing that we always look for when we do these.
I guess if it's if the bone is contacting, then that could click, or if there's fluid in it.
Okay, so now let's look at the open mouth positions on both sides, and what do you see?
Yeah, so it's the right side is anteriorly subluxing.
Well, okay, so both sides are hypermobile, and the condyle is actually going anterior to the eminence here, which we can see a little bit more on the right than on the left. So you've got a hypermobile joints bilaterally. What else do you see here?
Well, on the right side, the head is moving anterior to the disc, whereas on the left side, it's still posterior to it.
So what we have here now, the disc is in a normal position between the condylar head and the arcuate eminence on the right side. So we say that this patient has an anteriorly displaced disc, which captures on opening the mouth. On the left side, the disc stays anterior, both the anterior and posterior portions of the disc, so there's no capture of the disc. So that click on the right side is when the condylar head flips over the posterior edge of the disc to capture the disc, and that produces the painful click. Generally, this is considered a less severe form of disease than this because there's no capture here in this particular case. So here you're just going to have bone-on-bone motion all the way through. Here at some point, the condylar flips in and it captures the disc, and there's disc between the bones. Okay. So the primary reason we were doing the MR scans of the temporomandibular joints was really look at disc disease. And there are a lot of ways to look at it. So there are both direct signs and indirect signs. So the direct signs that you can comment on is a morphologic appearance of the disc. If it's crumpled, which is what we can see, this is kind of a crumpled disc here. This is the one that captured it as normal. It can be rounded because it just gets balled up from degenerative disease and no longer looks like a typical disc. It doesn't have the wide anterior, thin middle, and broad posterior portion. It's just one big ball. It will become completely flattened, or you can get a central tear, and you'll have both the anterior and posterior bands of the disc can be separated. So those are the things you look for in the disc morphology. And then the abnormal displacement. So typically you'll have anterior displacement in the closed mouth position, which may or may not capture when you go to the open mouth position. And when we did different motions, it could capture at different locations, which tended not to really matter. One of the reasons why we stopped doing the motion studies. Very rarely you can get posterior displacement, but that's very uncommon. And then you can also get lateral and medial displacement, which we'll see some examples of going forward. So that's looking directly at the disc, describing the morphology and placement of the disc. And then then there's, the location it is in the closed and open mouth positions. And then you can look for degenerative changes with flattening, osteophytes, erosions. I'll show some of those as well. And then there are indirect signs. If you have large amounts of effusion in the joint space, that means you've got pathology, just like it would in the knee or somewhere else. You can look for thickening of the posterior attachments as opposed to tearing of the posterior attachments. And then you can look at rupture of the retrodiscal layers, which is what we saw in those patients who had anterior displacements.
So capturing just means that there is an articulation between the disc and the condyle?
Capturing means that the entire disc is anteriorly displaced to the condyle in the closed mouth position, but in the open mouth position, it's in a normal position between the condyle and the arcuate eminence.
And what's the disc made out of?
It's fibrous tissue. It's made out of basically the same thing that a meniscus is made out of. And that's, as John said, it's often called the meniscus. And as far as morphology looks like, here we can see a crumpled disc. Looks like an anterior horn, posterior horn, thin portion, but it's all crumpled together. This is just more of a rounded. We don't really see the normal morphologic structures of the disc in this case. Here's one that's just completely flattened out but abnormally anterior displaced. And here you can see extensive erosion of the condylar head. We'll talk about that later as well. And here's a perforated one where we can see a separation between the posterior and anterior bands of the disc. So that's the kind of morphology that you're looking for when you describe morphology. Now, disc displacement, the normal position, the posterior part of the disc should be roughly around the 12 o'clock position. Generally, it's commonly a little bit more anterior to that. So within 30 degrees is typically considered within normal limits in the closed mouth position. Okay, this is a patient with left-sided pain. Sahar, what do you think of this case?
Okay, left-sided pain.
Notice that this is the right side.
So all the images are right side or just the middle one?
The patient had left-sided pain, and this is imaging of the right side.
The right. Okay, so I think we are looking at the open and closed mouth views. I think the last one is the
Closed
open mouth.
and open, right?
Yeah. So maybe there's some anterior displacement of the disc on the closed view.
This is T2. These both are T1.
Yeah, there's some increased stigma in the disc and T2 centrally. I don't see a definite perforation on the disc.
Well, on the T1 weighted images, we see a little bit of increased signal intensity within the disc, which is commonly seen in asymptomatic individuals. It's nice and dark on the T2. See a little bit of fluid, kind of borderline amounts of fluid in the disc. But this is the asymptomatic side. And
Okay.
the position of the disc here is a little bit anterior here, so it's really a borderline position in the closed mouth position. So I would just describe it as the disc being slightly anterior displaced in the closed mouth position, but there is normal positioning of the disc in the open mouth position. But this was the asymptomatic side.
Okay.
Okay, I believe. Okay, this is the symptomatic side. What do you think here?
Maybe there are some cystic changes in the mandibular condyle. I don't know if that's artifact or if that's real. Yeah.
Oh, no, that's real. And
That's real. Okay.
here, this is enough signal to really be abnormal. And notice the morphology of the disc is crumpled here.
Yeah.
This would be a crumpled morphology. That's not normal. On the T2 weighted image, we can see a little bit more than normal amounts of fluid, so there's an effusion in the joint space. And it's borderline anteriorly displaced here as well. So this is really a more of a degenerative type disc, and that was the symptomatic side.
Okay.
Okay, Thomas.
They typically don't do both sides, right?
Unless they're symptomatic, right.
Okay.
We will commonly just do one side, the symptomatic side. Okay, Thomas, what do you think of this one?
So 19-year-old male with painful click. So on the closed view, looks like the disc is anteriorly dislocated.
Yeah, this is probably the posterior edge, and it's clearly anterior dislocated. This is the central zone. This would be the anterior band. On the T2 weighted image, we see a little bit more than the normal amount of fluid, and we clearly see that the disc is anteriorly displaced, and the morphology isn't completely normal. It's kind of a flattened morphology on the T2 weighted image. Okay, here is the open mouth position.
Yeah, so the condyle captures on the open mouth view.
Yeah, and here there's probably tearing of those retrodiscal structures back in through here, but we see that it captures. And the painful click was when he captured the disc.
So 77-year male with jaw pain. So I think both of them are closed view.
Yeah, one's on the left is a T1, the right's a T2.
T2. Okay, so so the disc, the whole thing is a disc. No, the other. Okay. The disc is low signal, which
Okay, here's the disc.
right, and there is some increased signal within the disc too.
Well,
No, that portion.
you can see that the posterior part of the disc is definitely anteriorly displaced.
Right.
We can see that there's
Retro.
thinning here of the retrodiscal structures, so they're torn, or at least partially torn.
Okay.
And we get a little bit of a crumpled appearance to the disc.
Okay.
But the signal intensity within the disc is pretty normal.
Normally, yeah.
But this is an anteriorly displaced disc in the closed mouth position.
So this is open mouth then?
Okay.
No, this is
This is the open mouth
open mouth,
position.
yeah.
Closed mouth,
So,
open
okay.
mouth. So what's happening here?
So I see the I think it's the distance is also going small. I think the close to the bone on this image.
Okay. Well, actually, there's also the actual shape of the condyle here is a little bit hypoplastic.
Right.
What's happening here is the disc is being captured.
Okay.
Now the condylar head, there is disc between the arcuate eminence and the condylar head, but this is abnormally decreased translation.
Mm-hmm.
So here's a case where we have abnormal anterior displacement of the disc in the closed mouth position.
Mm-hmm.
It captures, but there is inadequate anterior translation of the condyle. So the differential here is the reason why you don't have adequate anterior translation here is not because of the usual reason that you have a big fragment of the disc here that's not moving and isn't capturing, because you're actually capturing it. So here, either the patient is not opening their mouth, maybe because of pain, or you have adhesions in the joint space, which limits translation. And sometimes you can tell that if you do both sides. If you have adhesions, sometimes the opposite side will move normally, but the abnormal side won't, in which case it's not poor effort on the part of the patient. In that case, the patient is opening the mouth because one side's moving properly. The side that's not moving is most likely due to adhesions. So in cases like that, having bilateral can sometimes be helpful. And come to think about it, I think I answered John's question wrong. Most of the time we do both sides.
I thought so, but I wasn't going to contradict you, John. You know me.
I know. No, you're right. We normally do both sides, and that's the reason, or one of the reasons. So this is anterior displacement with capture, but you have decreased translation. Okay.
Okay.
And the translation is not normal either. It's kind of like it goes from posterior to anterior and back. I was wondering if this patient may have some kind of systemic problem.
Yeah, I don't know.
Some kind of a degenerative disease or whatever.
I don't know. Most of these are thought to, if they have adhesions, it's thought to typically be due to prior trauma.
Yeah, but their condyle is so darn small.
Yeah, and if it's small, you certainly have to think about rheumatoid arthritis because it likes it.
That's what I was thinking.
But we can see that the cortical margins are intact, so we don't see any typical rheumatoid erosions. But, yeah, I don't remember the etiology.
We usually don't look at this joint in rheumatoid arthritis. We look every place else.
Okay.
I don't think you don't see that many TMJ problems in rheumatoids, do you, John?
Not that many, no, but I've seen a few.
I'm sure you have. I think I've seen a couple, but not many. But the problem is common. But they have so many other complaints that they don't complain about the jaw.
Right.
Okay. So it looks like we have anterior positioning of the disc relative to the condyle on the closed view. And then on the open view, it remains that way, and it looks like there's no capture.
Yeah, so this is anterior displacement without capture. There's probably a little bit of limitation in translation due to the mass effect from the uncaptured disc. Good.
So that shouldn't click, right?
It shouldn't click, that's right. Okay. Vanessa.
I'll take over for Vanessa. She's not here.
Oh, yeah.
One of the techs at Cool and Joe. Okay, 31-year-old female, 10 years ago, left TMJ pain and clicking. Now asymptomatic, 2-week history of right side TMJ pain and clicking. Okay, so left and right. So right off on the left side, that's no. I think on the left side is like a subchondral cyst in the in the head there, and on the right, I think that the head is a little abnormal, but just the shape of it, I don't know. I'm wondering if that's if that's normal variant.
What do you mean a little bit?
Sorry?
What do you mean a little bit? Both sides are quite different. The
right.
Are quite different.
Right, they are different. Yeah. So
what do you think is going on here?
So let me think for a second. They used to have left side. So maybe
the coronals. They're the coronals.
I mean, as Dr. Yaguda said, the jaws move differently when a person opens their mouth. So I'm thinking maybe if the patient was altering mechanics because of pain on the left, because it's degenerative change there, maybe that's causing hypertrophy of the bone on the right.
Well, no, the condyle does look different on both sides. The one on the left looks pretty normal, and the one on the right doesn't have a condylar structure to it. It doesn't look like a mushroom. It looks like
the one on the left.
the mushroom has worn away.
Yeah. Okay. So this is the left side on our right. And unfortunately, I should have put these the other way. The right side is on our left.
Okay, so there's a subchondral cyst on the left, and on the right side is just not a normal looking.
Well, okay, but notice how narrowed the space is here on the left side.
Yeah.
Let's go to the coronals. They're the coronals. What do you see here?
So again, just typical degenerative changes on the left, joint space narrowing of subchondral eburnation and cyst formation.
Remember, the left was symptomatic 10 years ago, but now is asymptomatic. So
right.
What do you think might be happening here?
So again, I don't know if this is the case, but maybe the patient's altering the way that they're opening their mouth, and they're just moving, they're shifting the jaw to the other side now.
Okay. Here's the MR scan. This is the right side, the symptomatic side.
Yeah. Okay. So here, the disc isn't. This is maybe a little bit anterior. It's a little bit. The posterior part of it is a little bit thinned out and
a little thin.
wrinkled, I guess.
Looks like it's pretty well positioned. Not a lot of fluid on the T2. And there's the anterior translation. I mean, that's the open mouth view.
Yeah, I think it's probably catching part of it there. It's definitely catching the disc, I'd say there.
Well, but it's captured before too, right?
Yeah.
The disc is really in normal position here anteriorly, and it's a little bit, margins a little bit poorly visualized, a little bit of increased signal intensity, but it looks like it's pretty normal position, and there's actually maybe a little bit of hypertranslation here. And if we go to the left side, what do you see here?
So here the disc isn't articulating at all. And then when the mouth is open, it's not even moving. I think the condyle is just staying where it is.
Oh, I'm sorry. Let's go back here. This is the T2 closed mouth. This is the T1 closed mouth. And you can see more of a rounded morphology. So this is chronic long-standing degenerative disease of the disc, which is anteriorly displaced.
Yeah.
And the open mouth position. It's probably still anteriorly displaced, though, and it looks like there's bone-on-bone contact here. So this is a situation where the abnormal side on MR is asymptomatic, and the normal side is symptomatic. And I think what happens here, and this is probably one of the reasons why treatments didn't seem to have good long-term prognoses when you compared them to controls, is that often the joints are most symptomatic early on when you still have a lot of innervated tissue there that's in the process of tearing or degenerating. That's when it tends to be very symptomatic. Once you have start having some degenerative disease, this tissue is probably not very well innervated, and often in the temporomandibular joint, the symptoms get less. And that's in part because it's probably a non-weight-bearing joint like the knee. But we actually saw that fairly frequently, that often the most symptomatic cases were the ones that were a little bit abnormal, but not real abnormal. And what you find if you do longitudinal studies is that people may come in with abnormal disc and be very symptomatic, but over time, the symptoms get less and less without intervention. And sometimes intervention can kind of screw up the joint. And I think that's why a lot of interventions for this disease lost favor, because the natural history, even if you go into degenerative disease, you can have dysfunction, but often they become less symptomatic.
Well, John, there is weight bearing, but it's in terms of clenching.
Yeah, there's forces on it.
Due to pain.
Right.
So there is weight bearing.
Well, yeah. I mean, there are forces across the joint, not weight.
I know it. I'm just saying that there is considerable pressure when you bite down on something.
Yeah. But that's something that can be controlled. Whereas if you have to put all your weight on it, then you really can't control the amount of weight unless you have.
Not at night when you're sleeping.
Okay. Okay, Sahar, what do you think of this one?
Okay, adhesion female right jaw pain for 2 weeks. And we have radiograph. We have.
This is what we looked at before we had CT.
Yeah, okay, we have closed mouth and open mouth. Seems that there is. It's moving. I think the canal is moving a little bit anteriorly, not completely probably. I don't know if he didn't try to open it or if he cannot open
Okay, closed.
the mouth.
But clearly they're opening their mouth and we're getting some rotation and translation there. Here is open and closed mouth views.
Open mouth. Okay, closed mouth. So the disc has some signal in it.
Yeah. What I want to point out here is there's the disc, but where's the condyle?
I don't see it.
Okay, and then open mouth view we don't see either. Okay, so what do you think might be happening here?
We have like dislocation.
Okay, good. So the disc isn't in the same plane, in the sagittal plane, as the condyle. So you need to look in the coronal images for this. And this is actually the coronal image here. And this is actually a displaced disc over here. And we can see all this soft tissue thickening around here. But this was a medially displaced disc. So instead of being displaced anteriorly, it was completely displaced medially. And go through the coronal images, it's much easier to see on the coronal images. But if you see the disc nicely, but you don't see the condyle in the sagittal images, then you're talking about medial or lateral displacement.
If you really want to enlarge the disc and look at somebody chewing, watch a cow.
Oh, okay. Right.
That's how people chew, but not at that extent. But there is rotation and sliding and flexion and extension in the jaw, just like an animal eating, i.e. a cow. But you probably never saw a cow eating, so I.
Yeah, right.
I don't know.
Yeah, you're talking to the wrong crowd here, John. Okay.
They're known as they're chewing their cud.
Right. Thomas, what do you think?
And what people do is jawbone. That's what we're doing.
Yeah. Thomas, what do you think of this one?
So 55-year-old female with painful click. So on the closed mouth, T1 on the left, I don't see the disc. So it could be dislocated medially or laterally.
No, the disc is right here. And that's where the T2 weighted images are helpful. You can see the contrast sometimes is better on the T2 weighted image, and this is the disc here.
Okay. Yeah, in that case, then
it's abnormal signals in it. So it's a little bit of a degenerative disc, and the morphology is a little bit abnormal, but as you can see, it's anteriorly displaced.
Right.
So the patient has a painful click. So what do you think the open mouth views are going to look like?
There should be capture on the open mouth.
So what do you think here?
So there is capture in the open mouth.
Yeah, great. Now, now let's go to the coronal images. And what do you think of the coronal images?
So looks like the disc is articulating on the first image. Yeah. And on the medial T2.
Yeah, so it's actually partly displaced medially here. And on the medial T2, we really shouldn't see a disc in this location. We can see a little bit of the disc medially displaced here. So so what happens in this case, the patient, it's anteriorly medially displaced in the closed mouth position, and then it captures in the open mouth position. This is sagittal right through this plane right here. Okay, so that's
while I'm thinking, I'll mention something. The reason boxers try to hit the jaw is exactly this joint. If you look at the brain there. How many millimeters is that away from the condyle? So the idea of an uppercut, for instance, in boxing, I did a little boxing in my younger years. The contact there is very, very close. And it's very easy to knock somebody out if you hit the jaw and that condyle hits the bone there and transmits the force to the brain, and down a guy goes, or a girl. I guess girls are fighting now too. Not in my day, but now they are.
Okay.
Well, they used to fight over boyfriends, but that's different.
Okay. So close.
Anyway, that's a joint where a boxer concentrates on to knock somebody out. Sorry, John,
it's okay.
didn't mean to.
Ahmed?
Yeah, okay. So closed and open view. So, so the disc is, I see on the top of the condyle on open view.
Okay. So here we really see just a little remnants of the disc. We have a little anterior osteophyte, which is an indication we've got some degenerative disease here. On the open view, we can see that it captures, right?
Right.
Yes. But then if we go to back to the closed view and we go in here more immediately, we can actually see a disc where we shouldn't see one. And this, I'm laterally, I'm sorry, that was laterally. So this is lateral. And then on the coronal images, we can actually see that this is a laterally displaced disc.
Right.
So the coronal images really are helpful in trying to differentiate where the
displacement.
Disc is.
Yeah, so lateral displacement.
Back in the days when people did surgery on these, I still think there is some done. So it's good to look at both the sagittal and the coronal images in describing the location of the displacement.
That's subluxed.
Yep.
Okay, closed view. It looks like the disc is anteriorly displaced with respect to the condyle. And here, not sure I see anything recognizable. On the coronal, it looks like the condyles aren't in the same plane. So
That's the nature of the.
Okay.
They didn't do it quite in the right plane.
Okay, so maybe the disc on the left looks like, or on the right, it looks laterally extruded.
So, you know, this
or
is
centrally.
the normal position. This is medially displaced.
Right.
And this one certainly
laterally
is abnormal. Anteriorly displaced. Laterally. So here we can see it's anteriorly displaced.
Right.
And here it's anteriorly displaced, but we're getting more lateral, so it actually looks like it's bigger lateral. And then
you're talking about the disc, right, John?
Right. And then here, this is anterior and a lateral displacement, and we can see there's medial displacement on the other side.
What's going on laterally on that side?
Here?
On the other side, sorry.
On the other side.
That, yeah.
I think that's just a normal.
Or up top, the black.
This,
yeah,
that's the bone.
Oh, that's bone. Okay.
And I don't know why there's artifact here.
Okay.
This patient might have had surgery on the other side. Anterolateral displacement. Anterolateral displacement. Okay. Sam, what do you think of this one?
I don't think I see a disc here. I think there's sclerosis in the head.
Okay. So this is closed mouth. This is open mouth. Maybe there's a little kind of remnant here, but there's not much left. Whatever it is doesn't capture. We've got bone-on-bone articulation, and we have sclerosis of the head.
Yeah.
And this is the arcuate eminence, which is a little bit shallow here. Here are the coronal images.
So there's erosion of the head
Yeah.
And there's again, I'm not sure I see a disc, but
Yeah.
it's very narrow joint space.
Very narrow joint space cyst. There's a little anterior osteophyte here, and this is someone who had prior trauma, and this is post-traumatic degenerative disease of the temporomandibular joint. Okay. Tom, let's see. No, Sahar, what do you think of this one?
Okay, yeah, I think this does exist, but it looks maybe a little bit like degenerated. There's some increased signal. And the condyle is kind of like anteriorly displaced on the first image.
What, the condyle is anteriorly displaced? This is posterior. This is
posteriorly. I'm sorry.
Okay, so what we see is a very abnormal morphology of the head, of the condylar head. The disc is anteriorly displaced in the closed mouth position. The arcuate eminence is abnormal and deformed. In the open mouth position, we have very little translation. We still see the abnormality of the head. We do not get capture of the disc, and we still have a very abnormal appearance to the condyle. And this is more severe degenerative disease, typically post-traumatic in this particular patient. Thomas, what do you think of this one?
So left-sided pain. So I think we have closed and open views. So the disc has abnormal morphology and it's anteriorly displaced.
Okay,
on both
there's an abnormal effusion here, and it's abnormally displaced in both the closed and the open mouth view. There's abnormal loss of translation in the open mouth view, irregularity of the arcuate eminence, and marked irregularity of the head with this large anterior osteophyte. And that's also typical of chronic degenerative disease of the temporomandibular joint. Let me think here. Okay.
Okay, so closed view, sagittal, I think. So I see the disc anteriorly.
Okay, so this is T1 closed, T1 open, and T2 closed.
Okay, so on I see the increased signal within the disc on T2 on the closed.
So what we see here is that there is a separation between the posterior and anterior elements of the disc. So there's a
gap between
the condylar head is really too posteriorly displaced, and the entire disc is anteriorly positioned, right? So that's all abnormal. And actually, I'm sorry. This is an osteophyte. Sorry about that. This is the disc, which has abnormal morphology. And if we go to the open mouth position, we see the abnormal erosion of the head, abnormal osteophyte. There's no capture of the abnormal disc. The contour of the arcuate eminence is abnormal as well. In the T2 weighted image, we can see fluid around the anterior displaced disc here. So this is anteriorly displaced disc without capture, but with severe degenerative changes of the contour head.
Oh.
This is severe DJD.
Okay. Right-sided TMJ pain with limitation of opening. So we're looking at the left side. So the closed view, the disc looks like it's right around 12 o'clock. Looks normal. And on
a little abnormal signal in the posterior band, but that's okay.
Little degenerative disease. The open part looks like it's capturing fine.
Okay, now here's the right side.
So the right side looks like there's abnormal flattening of the condylar head. There's anterior translation of the disc relative to the condyle. The condyle is a little posteriorly positioned, and then in the open view, it doesn't capture.
Right. And what about the arcuate eminence?
Looks like it's a little.
It's very abnormal. It should be more of a.
Yeah.
So what's happened here is you've got degenerative disease of the head, chronic anterior displacement of the disc, and you've got remodeling of the arcuate eminence here from bone-on-bone articulation. So this is a very degenerative, abnormal TMJ. Okay. Sam, what do you think of this one?
A lot of irregularity of the head, a lot of joint space narrowing, a lot of soft tissue thickening, looks like, at least in the picture on our left. I think there's a disc that's, the one on the right is a sagittal?
Sagittal T2.
I think there's anterior dislocation of the disc, if that's disc, and right, that thing, yeah. I don't know. And yeah, just closed, open. It's not really moving much. I guess this is adhesions here.
Yes,
Part of the change.
see a little bit of motion here. Very abnormal arcuate eminence, which you need to comment on when you have this kind of degenerative disease. Large osteophyte, marked erosive changes, kind of bone-on-bone articulation. Again, degenerative disease. So why don't we stop here? I thought we'd get through all of the temporomandibular joint. In fact, I thought we'd get through it in about 30 minutes, but we haven't. Why don't we stop here? Thomas, we're going to miss not seeing you at the dinner tonight.
Oh, yeah. Sorry I couldn't make it.
Yeah.
We'll miss you.
Yeah.
Well, have a good time, you guys.
You too, Dr.